Welcome back. Let's dive in. De escalation is the art of reducing the intensity of a crisis. You've started with good communication. Now let's talk about broader crisis intervention strategies to keep things moving toward a safe resolution. Firstly, manage yourself. Stay calm. In a tense situation, anxiety is contagious. If the patient sees that you are steady and unflappable, it can help ground them. This doesn't mean you act cold or robotic, it means you keep your cool. Take slow breaths yourself if you feel your heart rate rising. Keep your tone confident to convey that you know what to do. If you appear scared or unsure, the patient might panic more or lose trust. Confidence coupled with empathy is key. Like a captain guiding a ship through a storm, you acknowledge the storm, but you're not panicking about it. Next, consider the environment and remove unnecessary stressors. Many times during psychiatric calls, family members or bystanders are arguing, "Why are you acting like this?" or hovering anxiously. That can really ramp up a patient's stress or embarrassment. If someone is agitating the patient, tactfully get them to give some space. For example, "I understand you're worried, but it might help if we give John a little room to breathe. Could you wait in the other room while we talk to him? I'll come get you in a minute." If there are loud TVs, music, or other distracting noise, see if you can turn them down. Essentially, create a low stimulation environment. Fewer people, less noise, less chaos equals a better setting for the patient to regain control. Maintain a non threatening presence. We talked about sitting at eye level if appropriate. This can really help as long as you feel it's safe. Obviously, if the patient is unpredictably violent, you may choose to stay standing for quicker mobility, but for someone who's mainly upset or scared, sitting down a few feet away can be great. Keep your body language open and your facial expression compassionate. Sometimes just sitting quietly nearby while the patient vents or even cries can be very grounding for them. You become a calm anchor in the room. Provide honest reassurance. By honest, we mean don't lie or make promises you can't keep. Telling someone everything's going to be perfectly fine might ring hollow, especially if they are actually in a serious situation. Instead, reassure them about immediate truths. "You're not alone right now. I'm here with you." Or, "I'm hearing you, and I want to help." If they're afraid of being restrained or hospitalized, you can say, "Our first priority is to make sure you're safe and get you the help you need. No one is here to hurt you." Highlight any positive steps. "Okay, you're breathing a little slower now. That's good. Just keep taking those deep breaths." These kinds of comments can give hope and a bit of calm without overpromising. A great strategy is to involve the patient in making a plan. When people are in crisis, they often feel a complete loss of control. By giving them some choices or involving them in decisions, you return a bit of control to them, which can reduce resistance. Even small choices help. "Would you like to walk to the ambulance, or would it be easier if we brought the stretcher here?" Or, "Which one of these hospitals would you prefer to go to if you have a preference?" Obviously, only offer choices that are actually options. Don't give a choice about going to the hospital if, legally and medically, they really have to go. But if they feel part of the decision making, they're less likely to fight those decisions. Collaborative language like "let's do this together" or "let's step outside for some fresh air and talk more" can also guide them along. Keep the patient engaged and grounded in reality as much as possible. One method is to encourage some simple motor activity or focus. Paramedics sometimes talk about encouraging a bit of motor activity, not running around, but something like walking or deep breathing or even squeezing a stress ball if available. For example, if a patient is hyperventilating and panicky, you might guide them to breathe slowly with you. "Let's slow down a bit. Breathe with me, in and out." Or if a patient is pacing, you might actually walk with them side by side rather than forcing them to sit, as long as it's safe. This can make you seem more like an ally than an opposing force. Another example, give them a simple task like holding an oxygen mask or a bandage, something safe. It can redirect their attention slightly. These are subtle techniques and may not always be appropriate, but the idea is to channel their energy in a constructive way. Never leave them alone once you've made contact, especially if they are suicidal or severely agitated. If you have to grab equipment or step away, get someone else, another EMT, paramedic, or police officer, to stay with them, continuing the engagement. Even a few moments alone can be dangerous. A suicidal patient might make an attempt, or an agitated patient might bolt or harm themselves accidentally. Continuity of presence is reassuring too. "I'm going to stay right here with you. I'm not going anywhere." If the patient is really on edge, you might even ask a partner to bring equipment to you so you don't have to step away at all. Now, despite all these good efforts, sometimes the patient's behavior does not improve or even gets worse. Prepare for the unexpected. Have a backup plan with your team. If the patient suddenly becomes a danger to you or themselves and communication isn't working, you may need to use physical restraints or additional help. This is a last resort, but it's something you should be mentally ready for. Discuss with your partner or police beforehand. "If I say blank, we need to act. Keep restraint equipment, like soft restraints, handy if it looks like it might be necessary. We'll cover restraints and legal aspects in a moment, but from a crisis management perspective, sometimes, despite your best de escalation, you might have to intervene physically for safety. If that moment comes, try to do it in a coordinated, swift way to minimize struggle and always continue verbal reassurance. We're doing this to keep you safe, we're not here to hurt you, etc. To sum up, de escalation is about maintaining a calming presence, reducing triggers, involving the patient in their own care, and being ready if things go south. Many crises can be talked down with these methods, avoiding the need for force. It's a skill that improves with practice, and it's one of the most valuable skills you can have in EMS when dealing with psychiatric emergencies. Now that we've covered how to handle the patient in front of us, let's zoom out and look at the bigger picture, the mental health care system and how EMS interacts with it. Understanding this context will help you know what happens to your patient after you drop them off and why we do some of the things we do. Think of mental health care as a continuum or spectrum of services. On one end of the spectrum, you have outpatient care, and on the other extreme, inpatient hospitalization. Most people with mental health concerns are actually treated on the outpatient side. That means they live at home and go see professionals for help rather than staying in a hospital. Only the most severe or acute cases end up in the hospital or calling EMS. Let's break down the types of professionals and levels of care. At the basic level, there are counselors or therapists. These might be licensed counselors, social workers, or marriage and family therapists. People might see them for things like coping with stress, relationship issues, or mild depression, anxiety. It's talk therapy generally. For example, someone struggling after a divorce might see a counselor weekly to talk through their feelings and learn coping strategies. These are usually outpatient appointments. Psychologists are more specialized in mental health. They often have a doctorate in psychology. They can do therapy too, and also psychological testing. They handle more severe cases than a general counselor might, for instance, complex trauma or personality disorders. But one key thing is that in most places, psychologists cannot prescribe medication. They're not medical doctors, with some exceptions in a few states or in military settings. They often work in clinics or alongside psychiatrists. Psychiatrists are MDs or DOS. They went to medical school. They specialize in mental health and are the ones who can prescribe psychiatric medications, like antidepressants, antipsychotics, etc. Psychiatrists typically manage patients who have more severe mental illnesses, especially those requiring medication management. For instance, someone with schizophrenia or bipolar disorder will likely see a psychiatrist for medications and a psychologist or therapist for counseling. Psychiatrists can also admit patients to hospitals and oversee inpatient treatment. Now, when someone is in an acute crisis, like they are actively suicidal or psychotic and can't take care of themselves, the typical route is through an emergency department. Just like with chest pain or trauma, many psychiatric emergencies end up in the ED as the first stop. The ED provides immediate safety, medical screening to rule out those organic causes, which we as EMS also try to do, and then a mental health evaluation. In some places, there are specialized sections of the ED or separate psychiatric emergency services where these patients go to be assessed by mental health professionals, like psychiatrists or crisis workers. Some communities have crisis stabilization units or psychiatric emergency centers that function almost like an urgent care specifically for mental health. They might accept patients directly from EMS if the patient is medically stable. These places are designed to keep patients for 24 to 72 hours to manage the crisis and either discharge them with a plan or transfer them to inpatient care if needed. Another component is mobile crisis teams. These are teams, often a clinician and a counselor, sometimes with a police officer or EMT, that can respond to a person in crisis in the field, sort of like how we do, but specifically to handle mental health. They try to resolve situations on scene, maybe avoiding a trip to the hospital if possible by arranging outpatient follow up or calming the person down. Mobile crisis units aren't available everywhere, but where they exist, EMS might call them to scene or vice versa. For example, if you're on a scene and the patient is in crisis but not medically unstable, you might consult with a mobile crisis team to see if they can take over with mental health expertise. For inpatient psychiatry, if the patient needs more intensive care, they will be admitted to a psychiatric unit or hospital. Admission criteria usually involve either the patient being a danger to themselves, suicidal, unable to safely care for basic needs, or a danger to others, or so gravely disabled by their mental state that they can't function. Inpatient units are secure, doors locked, etc., and provide 24/7 supervision, medication management, therapy groups, etc. The goal is to stabilize the acute crisis, maybe over days or a week or two, and then get the person back to outpatient care. As EMS professionals, we might transport patients between facilities, say from an ED to a psych hospital once a bed is found, or from a psych facility back to a medical hospital if needed. So, where does EMS fit in all this? We're often the gateway or bridge. When someone out in the community has a crisis, we're called to intervene and then connect them with the right part of the system. Our job is to ensure safety and do initial stabilization, as we've discussed. Maybe de escalate them, treat any medical issues. Determine the appropriate destination. Usually, this is an ED because they'll do both medical evaluation and have psych evaluators. But depending on your local protocols, you might take certain patients directly to a psych facility, especially if medical issues are clearly minor or resolved. For example, some EMS systems allow transport of stable psychiatric patients straight to a dedicated psychiatric crisis center, bypassing the main ED, or maybe to a detox center if it's clearly just substance related and the patient is otherwise okay. Communicate with other responders. We often work with police on these calls. Either they called us or we called them. Law enforcement might have the authority to place a patient on an involuntary hold, like a mental hygiene arrest or whatever it's called locally, if the patient refuses help but is a danger. We coordinate with them for scene safety and sometimes for decision making on involuntary transport. Provide a thorough handoff to the receiving facility. The ED or psych center relies on our report. What we saw, what the patient said, any medications or drugs involved, their vital signs and medical assessment, and how they behaved for us. This info helps the next providers continue care. For instance, if the patient was calm with us after we talked to them but becomes agitated again later, the staff knowing that they were calm can help them figure out what changed. It's also worth noting the reality that the mental health system often has resource challenges. Over the years, there has been a reduction in long term psychiatric beds and emphasis on outpatient treatment. That means sometimes there's a shortage of inpatient beds for those who need them. As an EMS professional, you might see this manifest as long waits on hospital stretchers. Your patient might sit in the ED for hours or even days waiting for a psych bed. Unfortunately, it happens. It can be frustrating, and it means we sometimes take the same patients again and again because they aren't easily slotted into long term solutions. While we can't fix that as field providers, we can help by documenting thoroughly and giving a solid report, which supports the hospital in making the case for appropriate placement. Also, be mentally prepared for those longer transports or wait times with psychiatric patients. Keep using those communication and de escalation skills if things are delayed, because the patient may get restless or anxious during the wait. In summary, EMS is the front door to the mental health care system for many individuals in crisis. Knowing the resources available, from outpatient therapy to inpatient units, helps us guide patients to the help they need. And understanding that systems limits reminds us to be patient and advocate for our patients as they navigate what can be a complicated healthcare maze. Navigating the legal aspects of psychiatric emergencies can be tricky. These situations can blur the lines between a patient's rights and the need to protect them and others from harm. Let's break down some medical legal considerations that EMS professionals should be aware of. First, consent and decision making capacity. Under normal circumstances, an adult of sound mind has the right to make their own medical decisions, including refusing care. That's basic consent law. But what if the person is not of sound mind at that moment? In other words, they lack the capacity to make rational decisions. In EMS, we see this a lot. A diabetic with low sugar might refuse help because they're confused, or a psychotic patient might refuse because they don't even understand they're ill. The law typically allows us to treat these patients under implied consent. We assume that if they were in a normal, rational state, they would want life saving treatment. So, for example, if you have a patient running into traffic because of a hallucination, you don't need their permission to grab them and pull them to safety or to treat any injuries. You act as if they would consent to that help since they clearly are not in a state to consent. The same applies to, say, an acutely suicidal patient who downed a bottle of pills. Even if they say, "Leave me alone, I want to die," we proceed with care, like gastric decontamination, fast transport, because they aren't considered legally competent at that moment to refuse life saving interventions. The challenge is determining who truly lacks capacity. Generally, someone who is unconscious or delirious obviously lacks capacity. Someone in a full blown psychotic break likely lacks capacity because they may not understand reality or the consequences of refusing care. On the other hand, someone with a stable mental illness, who's just having some anxiety but can converse rationally and understand options, might still be considered competent. This is a judgment call and one of the toughest parts of these cases. The rule of thumb is if a patient is not oriented or is gravely impaired in judgment, they probably lack capacity to refuse care. When in doubt, it's wise to involve online medical control for advice and or law enforcement if needed, because forcing treatment on someone who is actually competent is a legal no-no, but failing to treat someone who is incompetent can be dangerous and also legally problematic if they come to harm. If a patient appears to be a competent adult who just happens to have a mental health history, remember they still have the right to refuse if they're fully alert oriented and not endangering anyone. For example, you might be called for a person with schizophrenia who is off their meds but not dangerous, just a bit disorganized. If they understand who they are, where they are, the situation, and the risks of refusing, and they decide not to go to the hospital, you typically cannot force them. In these cases, you'd want to make sure they truly comprehend the consequences and that there's no immediate threat. Have them repeat back to you. Can you tell me what will happen if you don't get checked out? If they can articulate that and still decline, have them sign a refusal, if your protocols allow, and definitely document thoroughly. Ideally, involve a family member or someone who can keep an eye on them if you have to leave them home. Now, many times in psychiatric emergencies, we lean on involuntary hold laws. The specifics differ by region, but every state and many countries have provisions that allow certain professionals to mandate that a person be taken for evaluation even against their will if they pose a danger or cannot care for themselves. Common terms include a 5150 in California, for example, for a 72-hour psych hold, or sectioning in some places, etc. Typically, law enforcement officers have the authority to initiate these, and sometimes mental health clinicians or physicians can as well. EMS professionals usually do not have independent authority to force someone into care beyond implied consent for immediate medical necessity. So we often rely on police to formally pink slip or section a patient. Practically speaking, what this means is if you have a patient who is refusing transport but in your assessment is clearly suicidal or psychotic and not safe to be left alone, you should engage law enforcement. Police can officially take that person into custody for the purpose of psychiatric evaluation under the law. Once that's done, you and the police and your partner can work together to get the patient to the hospital even if they resist, because it's now a legal detention for medical evaluation. For example, say you have a man who is hearing voices telling him to kill himself. He's refusing to go with you because he's paranoid about hospitals. You, as an EMT, shouldn't just say, oh, well, he doesn't want to go, case closed. That would be extremely dangerous for him and potentially negligent. Instead, you explain that he really needs further help, and if he still refuses, you involve police to enact an involuntary hold for his safety. It might feel uncomfortable to take away someone's freedom temporarily, but remember, the goal is to prevent harm. It's similar to not letting a severely intoxicated person just wander off into the cold night. You have a duty to care. Never leave an at-risk patient alone. This is worth repeating. If someone has expressed suicidal intent or has shown they're a danger, maybe they tried to hurt someone or themselves, you stay until the situation is resolved, one way or another. That might mean staying on scene until police can formally take custody, or transporting to the ER even if the patient isn't happy about it. Abandoning a patient in crisis could lead to a tragic outcome and legal consequences for you. If a patient runs inside and locks the door and you truly can't reach them, you'd call for law enforcement and maintain as much observation as possible. Don't just clear the scene without resolution. Now let's talk about restraints. Sometimes, despite verbal de escalation, a patient may become physically violent or so irrational that they try to harm themselves or escape a moving ambulance, etc. Physical restraint, and sometimes chemical restraint by paramedics, can save lives in those moments, but it carries risks, both medical risks to the patient and legal risks if done improperly. Always follow your local protocols, and whenever possible, get medical control approval for restraint use. Some protocols require a doctor's order, unless it's an extreme emergency. Often, if police are on scene and the patient is violent, they will apply their handcuffs or other restraints. That's fine. But if the patient is going in your ambulance, make sure you know how the patient is restrained and that it's safe. Handcuffs and back can be risky if the patient needs to lie down. It can impair breathing if they're face down, for instance. You might request police to cuff in front or use soft restraints on the stretcher instead. Use the minimum necessary force. That means don't pile on and hog tie someone just for yelling. We only restrain when there's a clear risk of harm. And when we do, we aim to do it with enough personnel to do it quickly and safely. Ideally, 5 people are used, 1 for each limb and 1 for the head, to subdue a struggling patient with minimal injury. We typically use soft restraints, like padded straps or cloth, to secure limbs to the stretcher. Avoid methods that impair breathing or circulation. For instance, positional asphyxia is a concern. A patient restrained face down can suffocate, especially if delirious or after a struggle. So, once under control, better to have them semi-upright or at least on their back with head elevated if possible. After restraining, monitor the patient closely. They're still your patient, not a prisoner. Check their airway, make sure they can breathe. Check circulation in extremities. Restraints shouldn't be cutting off blood flow. You should be able to slip fingers under a wrist restraint. And never leave a restrained patient unattended. Someone should be watching and reassessing them constantly. If you have a long transport and the patient is combative, strongly consider calling ALS for possible chemical restraint, sedation, if allowed, because fighting restraints for a long time can lead to things like acidosis or even sudden cardiac collapse in extreme agitation, sometimes called excited delirium. Documenting restraint use is critical. Write down exactly why you did it, like the patient became physically aggressive, attempted to punch crew member, what time you applied restraints, what type, soft cloth, leather, handcuffs, etc., and how the patient was positioned. Also document that you monitored their vitals and limb circulation every few minutes and any care given, like if you had to suction because they vomited or if ALS gave a sedative. This documentation not only protects you legally, we did this for these safety reasons and followed protocol, but it also provides continuity of care. The hospital needs to know what state the patient is in and what you've done. Beyond restraints, just in general, good documentation and reporting in psych calls is your friend. These calls can sometimes lead to accusations like, the EMT hurt me, or you didn't do anything for me. So, having a clear record of the patient's initial presentation, their exact words if they made threats or suicidal comments, and your actions is vital. For instance, if a patient says, "I'm going to kill myself," it's wise to quote that directly in your report. If they were threatening others, note that. If they refused and you had to involve police, document the steps taken. Pete refused transport. Police Officer X on scene invoked emergency hold per statute. PT then escorted to ambulance by police and EMS. Also, be aware of any mandatory reporting laws in your region. In many places, if someone has attempted suicide or is clearly a danger to themselves, that's inherently going to be handled by the psych system. But in some cases, EMS might need to notify specific authorities. For instance, child or elder abuse suspicion must be reported. If the patient's crisis stems from abuse, you may be obligated to report that to law enforcement or social services if it isn't already known. When you're unsure about the right legal move, call medical control. The on duty physician can give you an order to transport against the patient's will if they agree it's necessary, which provides extra legal cover. You can also ask for law enforcement assistance early if it seems like it might head that way. The overarching principle is, as always, patient safety comes first. The law generally supports EMS providers who act in good faith to save a life or prevent harm. If you genuinely believe a patient is not in a state to make safe decisions and could die or be seriously hurt without intervention, then intervening with help of police medical control as needed is the right thing to do. Conversely, if a patient is calm, coherent, and poses no imminent risk, forcing them into care could violate their rights and harm the therapeutic relationship. It's a balance we strive to get right, and it can be challenging. With experience, you'll get more comfortable judging these situations. When in doubt, err on the side of caution and life. If I don't act and something happens, can I defend that decision? Usually, it's better to have done something than to have walked away when someone was truly in danger. Thank you all for joining me.